Good afternoon all. Thank you for inviting me here for this lecture. I'll be talking about my experience that I had with injection laryngoplasty as an office-based procedure. The main aim that I have with this presentation is to answer a few questions that we all have in our minds when we think about unilateral vocal cord palsy. So first is, how does the patient present to us when he has a unilateral vocal cord palsy? What are the diagnostic armamentarium that are present with us that we can use to diagnose correctly the case and then to treat it? What are the various treatment options that we have and which one to be used and when? We can have a lot of discussion on this, and I know there will be a lot of difference of opinion on which ones to be used and when to be used. Then approaches to the cord augmentation and how it's done, choice of the material for the augmentation, and what the effect has on cord medialization with respect to the respiratory parameters apart from, as we all know, the voice parameters. So starting with my talk, I'll start it with a case scenario. A 29-year-old male presents to us to our OPD with a voice change which happens after a surgery. He underwent a hemithyroidectomy 4 weeks ago, and post-surgery he noticed that he has a change in voice. He thought it was breathy and it was hoarse. It was difficult for him to raise his pitch and he was unable to sustain long conversations. So when he came to us, as the basic thing, what Dr. Subramaniam Iyer said in the morning session, the first thing that we do is an indirect laryngoscopy. Most of us would defer and would directly go ahead with a fiber optic or a Hopkin endoscopy. So we did a laryngoscopy, the indirect laryngoscopy or a fiber optic laryngeal endoscopy, and we saw that he had a vocal cord palsy on the left side. So a laryngoscopy and a stroboscopic picture. This is the video, and we can see that the left side vocal cord is not moving. On stroboscopy, you can see that the waves are present, although mildly hampered, and the person has a glottic gap more towards the posterior ray rather than in the anterior part, and that is the reason why he has that breathy and rough voice. So, a glottal insufficiency that is present can be caused by an uncompensated unilateral vocal cord palsy, which reduces the voice quality, and immobile vocal folds and a sequential glottic gap causes the air to leak and deteriorates the mucosal waves, resulting in the hampered mucosal wave that we saw on stroboscopy, resulting in dysphonia and a reduced quality of voice, and subsequently a reduced quality of life. So there are various therapy options that are present with us in our armamentarium when we talk of unilateral vocal cord palsy, which are based on the size of the glottal gap. Now, the voice therapy is considered the most suitable option for patients with a glottic gap less than 1 millimeter, because we consider that much of gap can be compensated with just voice therapy. The injection augmentation or an injection laryngoplasty is reserved for those with small, that means 1 mm, or a medium size, that means 2 to 3 mm of glottic gaps. Anything more than a 3 mm of glottic gap, I'll be a bit skeptical to take the patient up for an injection laryngoplasty, because I know that the patient will still have a persistent glottic gap even after an injection laryngoplasty.
So usually for post-therapy, unilateral vocal cord palsy, how long will you wait for doing all these things? Because the cord may recover in due course of time, or the other cord may compensate in due course of time.
So I totally agree. Even if I am the person who has done the thyroidectomy and I am very sure that the nerve has been preserved, if the person on post-op day 1 has a vocal cord paresis or palsy and he is symptomatic, I will give him an option for an injection laryngoplasty if he is a professional voice user, or if his profession actually relies on voice. If he's a lawyer, he's a doctor, he's a teacher. Even when I know that the cord will recover in due course in 2 months, I think I will give him this option, that he can have this option of an injection laryngoplasty in which I can inject him with some material that will resolve in another 2 to 3 months, the time during which the nerve will recover and the cord will come back to its normal function. So, again, as I said, sir, there might be different opinion from different schools of thoughts.
What injection you use? What needle?
Sir, we did a 24 gauge needle and a high-rise injection, 24 milligram per ml concentration.
Come again?
24 milligram per ml concentration of a high-rise Juvederm, that's a commercially
I'm
available.
asking the needle.
24 gauge needle, sir.
24 gauge.
Yes.
Length?
I'm not sure. Sorry.
2 inches.
So, less than an ml, sir. The injectate comes in a 1 ml pre-formed, and I think in only few of the patients I could inject one. Most majority of them are around 0.7 to 0.8 ml.
Do you inject at what place exactly?
So we try and inject at multiple sites. It is 2 points where they say it should be anterior 1/3 and middle 1/3. The posterior third is usually not done.
Which place you inject? You inject in the submucosa?
Sir, we do it in the ring case. Try and do it just in the ring case.
How do you assess whether it is in rinkies or?
Sir, again, my video would show that my assessment was wrong. Some of it did go into the subglottic space also. So it's very difficult to.
You are coming from below.
Sir?
So you are entering
Yes, sir,
the
yes, sir,
from
yes, sir.
below.
We are coming from
So
below.
how come you know that you have entered the empty space perfectly?
Sir.
Because your upper surface and lower surface will be hiding the view of.
Yes, sir. Very difficult. What I would say is probably the initial injections probably went at different places. So very difficult to assess that we are probably there in the ring.
One last question. You showed there were some failures in your some 8 cases, 5 cases of failures.
Yes, sir.
Did you analyze what were the reasons for the failures?
So probably there were high vocal cord palsies where even after medialization the level was not met properly. So even on indirect laryngoscopy or a strobe, it felt as if the cords are meeting together. There must be a vertical gap which was there, which
I
could
think
not
that
be
was the
met.
reason for the dysphagia that has not improved.
Yes, sir.
Thank
So
you.
that was anyways there in 3 patients. So I think I was not hoping for a very significant improvement in those 3 patients.
Thank you. Very nice presentation. Excellent preparation and exhaustive. Thank you. Thank you so much.
Thank Dr. Suchita and the chairpersons for not only a good presentation but also a thought-provoking discussion. At this onset,